and it gives me a great pleasure to introduce the first speaker, Professor Steve Humphries. He's a professor of cardiovascular genetics at University College London, and he's going to talk about hypercholesterolemia, familial or not. Professor Humphries, thank you.
I'm going to talk about monogenic FH and its work that was carried out in my group at UCL over a number of years, and I particularly want to acknowledge the people whose names are mentioned at the bottom, and I'll mention some other names as we go through. So here's the structure of the talk. I'll be talking about DNA tests for monogenic FH and polygenic hypercholesterolemia, and then I'll explain about the CVD risk in these two different groups, and then how we can use the information we get to develop a personalized medicine approach, and then the use of the what we call the LDL cholesterol polygenic risk score in different ancestry groups. So let me move this out of the way. That's good. Can I move that out of the way? I've got various things in my getting in the way of what I can see. I hope it's not in the way of what you can see. Reduce that as well. Okay, that's much better. So here's a pie chart of the genes where we know mutations cause the monogenic form of familial hypercholesterolemia, or FH. And worldwide, the most common cause is a mutation in the gene coding for the low-density lipoprotein receptor, LDLR. In the UK, more than about 93% of the times where we can find a mutation, it's in that gene. The second most common cause is a mutation in the gene that codes for apolipoprotein B, or ApoB, and this, of course, is the protein that's the major component of LDL. And there's one common mutation which alters an arginine at position 3527 to a glutamine. And in the UK, this explains maybe about 5%, maybe 6 or 7% of the FH patients. This particular variant is the most common single cause of FH in the UK, and it is present in many countries worldwide, but it's also absent from a number of countries, and I can talk about that later if you're interested. Third most common cause of FH is a gain of function mutation in PCSK9, and you'll be hearing a lot more about PCSK9 and agents that block its activity. So I won't go into explain any more details, but it's the least frequent, but I think often the most severe cause of FH. In the UK, about 2% of patients carry a variant in that gene. And finally, and most recently, it's been found that a 3-base pair deletion in the gene for apolipoprotein E, which removes one amino acid, a leucine at position 167, can also mimic the FH phenotype. And in the UK, the frequency of that is about 2%. Now, since April 2021, DNA tests for FH have been offered by all 7 of the NHS diagnostic genomic laboratory hubs, and they've been paid for, if you like, from the government. Obviously, someone has to pay for them, but you as a referring clinician don't have to cover the costs. And this has made testing for FH much more accessible to clinicians and to patients. And the laboratories all use what we call next generation sequencing, NGS, to capture and sequence the exons of all the genes that we're interested in one run. You can actually combine samples from up to 96 different individuals and handle it in one run. Costs have fallen quite considerably, and the time taken to report is now much shorter than it used to be. So you can hope to get a report back in 4 to 6 weeks. So the immediate question is, what is the mutation detection rate? And in the labs that have been carrying this out, in about 60 to 70% of individuals who've got a very definite diagnosis of FH, if you're using the Simon-Broom method, or have a Dutch Lipid Clinic network score of over 8, you can find a mutation in that sort of group. But if you're only possible or probable FH, the detection rate is much lower. And since individuals with possible or probable FH are about 2/3 of the clinical referrals and 1/3 definites, overall, the laboratories are finding a mutation in about 20, maybe 30% of the referred individuals. So that's good. We know what to do with those individuals. We know how to manage them. We know that we need to test their relatives to see if they've also inherited the FH causing variant. But the question that's been bothering us for many years is what's going on in all the rest of the individuals who've got a clinical phenotype of FH, but haven't got a monogenic cause that we can find. So we put forward a hypothesis that having a large number of common genetic variants that each raise LDL cholesterol by a small amount could mimic monogenic FH. And we tested this and published a paper in the Lancet in 2013, and the title and the authorship is shown here. By that time, genome-wide association studies had identified many SNPs, up to 90 SNPs, each associated with modest LDL cholesterol raising. So we used the 12 of the most common LDL raising SNPs, the single nucleotide polymorphisms, and the ones who had the largest effect, to make what we called a polygenic risk score, or a PRS. We compared the mean PRS in a group of UK mutation negative FH patients, and then a replication group from Belgium, compared to 3,000 healthy subjects from a population-based study called Whitehall 2. And the results showed that in at least 80% of the non-mutation FH patients, a polygenic cause of their elevated LDL cholesterol is the most likely explanation. The results were confirmed in the Belgian patients and now in samples from 7 other countries. So let me just take you through this data in a bit more detail. So we had 12 SNPs, and if you look here on the panel on the left, let's say SNP A, it's either an A base or a C base, and A is the lipid raising allele. Individual 1 has 2 AA, so we can simply give them the score of 2, as you can see in the table below. Individual 2 is an AC, so they score 1. Individual 3 CC, they score 0. And you can see the same logic is applied to SNP2, where T is the lipid raising alleles, and then you simply add up how many lipid raising alleles an individual has. In the table on the right here, you can see the different genes that we were using, and interestingly, all 3 of the genes shown in red, in fact, I should also put ApoE in red, where we know that mutations can cause monogenic FH, they also have common variants that associated with raising LDL cholesterol. But what you can see here by looking at this column marked beta, this is the effect size. So the effect size actually is differs quite a lot between the different SNPs. So using just a simple gene score, it assumes the SNPs are of equal and additive effect. And what you can see clearly here is that's not the case. So we can improve our precision by scaling for the size effect of each SNP, and we call this a weighted score. So here is what the score looks like, just the number of alleles in the healthy people from the Whitehall 2 study. You can see the median is 12, the range 7 to 19. And what you would predict is that individuals who've got 7, 8, or 9 of these LDL raising alleles will have the lowest levels of LDL, and those who've got 16, 17, 18 will have the highest levels. And that's exactly what you see. Here I've divided the individuals into deciles of the score, and what I've plotted here is the mean LDL cholesterol, and you can see that it goes up in a very strong linear fashion. So we've got an excellent genetic instrument, and we can now compare the weighted scores between our patient groups. And in red here, you can see, in green here, you can see the distribution in the healthy individuals who don't have FH, and in red, the individuals who've got clinical FH, but where we can't find a mutation. And you can see the histogram in red is shifted to the right in a highly statistically significant way. And when we looked in the replication sample, we found exactly the same effect. And just to give you a feel of this, 54% of the FH mutation negative individuals are in the top 3 deciles of the score. If this was random, you'd expect 30%, so almost twice as many, and 11% in the lowest 3 deciles. So you can see that this effect is really quite marked. And what we said in the paper is that this higher gene score in the mutation negative group compared to the controls suggests that in a significant proportion of this group, the elevated LDL cholesterol can be explained by a polygenic component. So Why is this important? Well, clearly, if we want to search for a new FH gene, what we need to do is look up. There's no point in looking at patients who haven't got a mutation but have got a high score, because we know they've got a polygenic cause. So what we need to do is just look in the no mutation, low score FH patients. So it's got an important research aspect. It's also going to save the NHS money, because in the early guidelines for what to do, how to manage people with FH, it was thought that we should just cascade test anyone who's got FH using lipid levels. And now we realize, because of so many will have polygenic hypercholesterolemia, it's much less cost effective to do the cascade testing in these. And so when the NICE guidelines were updated, they stated DNA test and only cascade from the mutation positive patients, because on average 50% of their first degree relatives will have inherited the FH causing variant and will have FH. So it's got important aspect for the NHS. And as I'll talk to you, it's got clinical utility. If you don't have the PRS at your hand to be able to use, clinicians and patients are only given a genetic cause of their FH phenotype in, as I showed you, maybe 20, 30% of cases. But with the polygenic risk score, a genetic cause can be reported as highly likely in individuals in deciles 6 to 10, intermediate likelihood in deciles 4 to 5. It means that the overall diagnostic yield, where you've got something useful to tell the patient, increases from 20 to 30% to maybe 70 or 80%. And then, although I'm not going to show this data here, we demonstrated in a paper we published in 2017 that polygenic patients, so they've got clinical FH, we match them for LDL cholesterol. And if you've got a polygenic explanation for your phenotype, you have thinner carotid IMT and lower coronary calcium score than LDL matched monogenic FH patients. And this lower risk of CHD means that those with a polygenic cause can be managed by statin treatment by GPs and don't have to be referred to tertiary referral centers for their management. So what's the evidence for the lower risk of CHD in those with polygenic hypercholesterolemia? This is a paper that was published in 2016. It was over 20,000 individuals that were looked at, and a small number were found to have FH by next generation sequencing. What you can see here is that this is the odds ratio for CAD, and the individuals have now been divided into quintiles of LDL cholesterol, and the odds ratio in the lowest quintile in the non-FH group has been set at 1. And as you'd expect, as the amount of LDL you have goes up, the risk of heart disease goes up from 1 to about 7.7. But what you can see is that if you have an FH causing mutation, it doesn't matter which quintile of LDL cholesterol you're in, you've got maybe between 2 and maybe 3-fold higher risk of heart disease. And so what this says is that having a mutation is a really important predictor of your future risk. And what we believe is going on here is that those with an FH mutation have had a lifelong exposure to elevated LDL cholesterol, and therefore they have higher CAD risk than those with a polygenic environmental late raising of the LDL cholesterol as they get older. And let me just point out how important this concept of the LDL cholesterol burden is. And this is the sum of the measured LDL times age, and it's the same sort of concept as smoking pack years. And what I've done here is drawn in green, as you can see, the cumulative LDL cholesterol burden in green in individuals who don't have FH, and we've drawn sort of an arbitrary threshold here for developing clinical CHD at about 160 cumulative millimoles, and non-FH individuals cross this threshold at 55 years. So that's the time when they are at risk of having a CHD event. What you can see in blue here, if you're homozygous for FH, you cross that threshold at 12 years. So a 12-year-old homozygous FH individual has the same burden as a 55-year-old non-FH individual. In red is shown the line for heterozygous FH, crossed that at 35 years. And this explains why an untreated heterozygous FH patient has a risk of developing heart disease about 20 years younger than a non-FH individual. And what can we do? Obviously, we can treat individuals with a statin. And in light blue, if we start a high-dose statin at the age of 18, then that threshold is crossed at the age of 48. So clearly that's a benefit, but you've still lost maybe 7 or 8 years of healthy life. Whereas if you start a statin at a young age, say at the age of 10, then you can actually you can cross that threshold essentially at the same time as in a non-FH individual. And it's this concept of the LDL cholesterol burden and the benefit of starting at a young age that led to the NICE guidelines, and most of the guidelines that are now recommending that a low dose statin should be considered and initiated at the age of maybe 10 years. Now, here's another paper that was published more recently. It was based on the Biobank study. And the aim of this was to compare CVD risk in those with monogenic FH, called MFH, polygenic hypercholesterolemia, PGH, and then non-genetic hypercholesterolemia, which is called NGH. So the Biobank data, individuals 40 to 69 years, they identified 277 individuals with mutations in the usual suspects. And then they matched these with individuals who were in the 95th percentile of the LDL-C polygenic risk score, based on, in this case, 223 SNPs, and that's the PGH group. And then they matched them with a high LDL, low PRS, the NGH group, similar size. And the definition of cardiovascular disease is shown here. So first, let's look at the CVD risk by LDL SNP score, setting the hazard ratio at 1 in the lowest decile. You can see, as you'd expect, the risk for heart disease increases as the SNP score goes up. And the score is strongly associated with CVD risk, 35% higher in the top decile. What about now for monogenic FH? Here in black, you can see is the event-free probability in those who don't have FH. And in this pink color, it's those who've got monogenic FH. And as you'd expect, they're having events at a much faster rate. In fact, they were 3 times more likely to have had a CVD event at 55 years than the non-FH group. So just what you'd expect, both having a high PRS and monogenic FH increases your risk of CVD events. Now, this is the very clever bit of analysis that they did. This, first of all, shows you that all 3 groups, LDL plus, polygenic plus, and the monogenic plus, all were matched for LDL cholesterol. And then they looked at a time to event analysis, and you can see that compared that the monogenic group had the fastest rate, the LDL cholesterol group had the slowest rate, and the polygenic group had an intermediate rate. So what this is saying is that even though the cholesterol levels is very similar, it's essentially the same in all 3 groups, that there's a very different outcome depending on the cause for you having this high LDL cholesterol. And again, here, just in looking at the adjusted level, if you set the hazard ratio for heart disease in the LDL only group, the low polygenic score is 1. The polygenic score, it's about 30% higher. And in the monogenic, it's almost 2-fold higher. And so it comes back to this LDL cholesterol burden, highest in the monogenic, lower in the polygenic, and lowest in the non-genetic. And our conclusion from this is that polygenic risk score has a clinical utility. And then just to finish this, there's now mounting evidence that those who have both a monogenic cause and a high polygenic risk score have greater CVD risk than those with monogenic FH and a low score. This was a meta-analysis of over 1,000 mutation-positive FH patients, setting the hazard ratio for heart disease in the lowest decile as 1. You can see that in those in the top 2 deciles of score, the hazard ratio for heart disease was 78% higher, and is in part, but not fully explained by their high LDL cholesterol. So I believe that based on this data, it's appropriate to consider using more intensive lipid-lowering therapy and even lower LDL cholesterol on treatment targets for the mutation-positive group who've got a high PRS. So this is how I see that things should be working. A clinician sends a blood sample of an individual who's got clinical FH to the diagnostic lab. If the report says we found a monogenic cause, you do this: lifestyle advice, healthy diet, exercise, quit smoking, intensive statin therapy. This is a rather old target. The current targets based on the EAS are for LDL much lower than that. And then clearly what you do is systematic cascade testing of all close relatives. But what do you do if the report says no monogenic cause found? You then look at the probability of polygenic hypercholesterolemia, and those in the high decile for all of these individuals, obviously you then give them the same lifestyle advice. For these two groups, confirms a genetic cause for the high cholesterol. And for all of them, NICE says you can refer them to the GP to estimate their 10-year CVD risk using an algorithm. The one in the UK is QRisk, to lower LDL cholesterol and other CVD risk factors. And if you're monogenic and you're in a higher decile, I think you should consider greater LDL-C reduction, because their lifetime burden and their CVD risk will be higher. And then this low decile group, so they're phenotypically clinically FH, but they don't have either a monogenic or an obvious polygenic cause, then there's a good suspicion that there's some other gene cause going on there. And these are the individuals who you could consider carrying out other research to identify novel FH genes by doing whole exome or whole genome sequencing. We've been going back to our clinical colleagues and asking them, do they think that having the polygenic risk score is useful? And they almost all said, yes, it's useful for a number of reasons. It gives clarity about the diagnosis. It's useful for offering a potential explanation for their condition. It promotes adherence with lifestyle and treatment. It makes them less guilty about a high cholesterol. It's not because of their lifestyle, because it's a genetic etiology has been identified. And the clinicians say the patients are more likely to accept statin treatment and less likely to try to manage dyslipidemia with diet and lifestyle measures alone. And just a couple of quotes from some of the patients. This is a Caucasian female. Do you have any comments where they're giving you the result of polygenic hypercholesterolemia was helpful? Very helpful, absolutely. I wouldn't take my high cholesterol so seriously if I hadn't been told that. It's also reassuring because though it's genetic, the effect of multiple genes will be diluted out by the time it gets to my grandchildren, and I worry about them. And I won't read these through. The same sort of things were echoed by several other patients. Now, I just want to finish by pointing out that we do have the issue that we need to think about of whether we can use the same score in individuals of European ancestry, people from the Indian subcontinent, and people of African ancestry. And the first thing that we were able to address in this paper from Jasmine and Marta Futema was to look what the prevalence of FH causing variants was in these three different ancestry groups in biobank. You can see the prevalence in the European group was 1 in 288. In the in people of African origin, it was 1 in 260. And in the Asians, it was 1 in 226. Although these numbers look different, you can see the confidence intervals overlap. So the take-home message of this is that the prevalence of FH-causing mutations is really exactly the same. It's likely to be very similar, if not the same in all three groups. Second thing we checked out is carrying an FH-causing variant associated with higher LDL cholesterol in all three groups. And you can see in there those who don't have the mutation in blue, and in those who do have a mutation in pink, it's significantly higher in all the individuals. But what we have to remember is that, not surprisingly, here is the line showing the mean score in the white group. And you can see in the Black and Caribbean groups, the mean is very significantly lower. And in the South Asians, it's slightly lower, although it is also statistically significant. So we need to be careful when we're using these groups. And I think because of shortness of time, I'll skip this. So just to conclude, in all ancestry groups, the score is highly significantly associated with difference in LDL cholesterol. Significant differences between the different groups, meaning it'll be necessary to use ancestry-specific cut points, but it supports the use of this polygenic risk score in all different groups in preparing the clinical genetic diagnostic report. I'm going to skip this slide as well. So in summary, this polygenic risk score has clinical utility. We have the data we need. It increases the proportion of index cases with a genetic cause from about 20% to 80%. and it's useful to risk stratify both FH mutation positive and FH mutation negative cases for enhanced lipid management. Based on the prevalence of about 1 in 280, we'd predict more than 200,000 FH patients in the UK, but of these, only 8% are currently known. And the NHS has a long-term plan ambition of finding 25% by 2023, which obviously has been missed. And it depends on multi-pronged approaches. We need to educate and support general practitioners. We would like to be thinking of child-parent screening, and we need to increase the healthcare professional workforce to be able to deal with all the individuals that we're going to find. So just to finish now, what I hope I've persuaded you is that the clinical phenotype of familial hypercholesterolemia can be reached by having cholesterol levels above the diagnostic cutoff, because either you've got a monogenic cause, having a mutation in one of these genes, and these individuals have got particularly high CHD risk. They need to be treated with high intensity statins in a lipid clinic. But there's a large number of people who've got many of these lipid raising SNPs. They have lower heart disease risk. GPs can use algorithms such as QRisk to estimate CHD and CHD risk and treat them. And this is a paradigm example of using genetic information to be able to risk stratify and manage a patient with precision medicine. And I'll stop there, and I'm happy to take questions.
Thank you. Thank you very much. It's really, really great presentation. There are a couple of questions in there.
Yep.
What about familial hypercholesterolemia in women in childbearing age, i.e. statin use when planning pregnancy?
The advice from all the guidelines, UK and everywhere else, is that statins are contraindicated whilst planning pregnancy and during and whilst breastfeeding, because of the risk that the statins might cause congenital birth defects. The evidence that this occurs is actually not only, when I say minimal, but there is no convincing evidence that that's the case. However, it's better to be safe than sorry, and so at the present time, statins are contraindicated. However, if a woman, and this often is the case, finds that she is pregnant and she's still taking the statins, there's almost no cause of concern, but they will then be recommended to stop taking them quite soon. And this is a problem. This is one of the reasons why women with FH actually tend to have higher lifetime CHD risk, is because for many women, they're not able to take statin lipid lowering therapy for maybe 5 or 6 years if they have several children.
Thank you. And this is about QRisk scoring and the SNP scores.
Yeah.
Would you recommend using QRisk scores in SNP scores when those with higher SNP scores?
Yes, I think that's perfect. It's perfectly reasonable. As you know, the guidelines all say do not use risk algorithms like QRisk or Framingham to estimate an individual who's got clinical FH, estimate their CHD risk, because often a young individual, say they're in their 30s, they don't smoke, they're quite fit, they're not overweight. Their only single risk factor is LDL cholesterol, and their Q risk will come out as very low, and then they won't qualify for lipid lowering therapy. But we know they're actually at high risk because they've had high LDL cholesterol since birth. So all the guidelines say don't use it for monogenic FH. I think using it for polygenic hypercholesterolemia is perfectly reasonable, and then you could simply modify, you can lower other cardiovascular risk factors, obviously LDL cholesterol, one of them, but others, smoking, body mass index and things. So yes, I think it's perfectly reasonable.
Thank you. Professor Wierzbicki is a consultant chemical pathologist at Guy's St Thomas's Hospital and King's College London, 1 and a bit mile away from me. It's great to see you here, and the talk is going to be focused on diagnosis and management of severe hypertriglyceridemia. Thank you very much.
Thank you. So we're going to move away from familial hypercholesterolemia to the other area that there's sort of often sort of confusion about understanding and about management. So hypertriglyceridemia syndromes are quite common. The severe ones have an incidence of about 1 in 10,000 or more. The moderate ones you can find, depending on population prevalences of obesity and diabetes, can range up to about 10–15%. I'm going to be mostly concentrating on the severe end of the spectrum, but I will say a little bit more about the medium end as well, because most of the low-grade triglyceride elevations can be dealt with through standard protocols, just simply because they affect non-HDL cholesterol, and I'll say a few words about that. So the causes and consequences of triglyceride disorders, amongst the severe ones, the so-called Friedrichsen type 1, type 5, and to a lesser extent type 4, those are either monogenic or heterozygotes with other factors. So we're again into an interaction between polygenic inheritance and monogenic inheritance, just as we've heard about with familial hypercholesterolemia, but a slightly to a greater extent. We have a number of other sort of monogenic disorders, and these are the apolipoprotein E variant disorders. They're not mutations, they're too common. We have something called familial combined hyperlipidemia, which remains a little bit of an enigma, though there are some thoughts about what the causation may be. And those are sort of the type of things that we look for. So the real basis for treating hypertriglyceridemia in the vast majority of cases is their contribution to cardiovascular risk. And if you look at individual risk factors, then just as for cholesterol or for reduction in HDL, higher triglycerides are associated with risk. However, if you actually add in the facts of HDL, then the triglycerides begin to disappear in risk factors in multi-analysis. And what actually turns out to be the strongest predictor is the non-HDL cholesterol. So the difference between total cholesterol and HDL. And that basically increases as your triglycerides go up, and that parallels your cardiovascular risk up to severe levels. And so non-HDL is a very nice, easy thing to get a handle on. It's directly proportional to apolipoprotein B levels if you use those. And you can, many guidelines now have targets for non-HDL cholesterol, just as they have for LDL cholesterol. For rough purposes, a non-HDL is about 0.3 millimoles per liter, or it's about 0.7 or 7 milligrams per deciliter greater than you would expect for the LDL cholesterol. And that's a rough rule of thumb to use in moderate triglyceride disorders. Statins, because they activate LDL receptors. LDL receptors clear two things. They clear LDL particles through the ApoB 100 terminal binding domain, but they also clear triglycerides through the ApoE content of triglyceride-rich particles, and therefore they will also reduce triglycerides as well. So statins remain the first-line therapy for people with moderate triglyceride disorders. In terms of how we diagnose them, well, we use basic lipid profiles. The traditional way of calculating LDL cholesterol, the Friedewald equation, underestimates LDL cholesterol in people with high triglycerides. The new formulas, such as the Sampson or the NIH equation, are better. They're actually proof to triglycerides of up to 8 as opposed to 4. But you can also measure LDL directly. This is a little bit method specific because some of these methods see more remnant particles than others. But direct LDL measurement is used in some laboratories when triglycerides go high. You always in high triglycerides need to measure glucose and HbA1c. As I said, the commonest link is with the metabolic syndrome and with diabetes. And increasingly, as part of that spectrum, non-alcoholic fatty liver disease. So higher ALTs would tend to go with this group as well. For more detailed genetic profiling and detailed phenotyping, you can look at apolipoprotein E genotype. I'll say a little bit more about that. You can use ultra-specialist tests, and ultracentrifugation is still used as that. In some countries, you have the ability to actually address triglyceride fractions and subfractions like LDL subfractions through MR lipoprotein subfraction analysis. And to a small extent, we use enzyme assays, though those are going out a little bit out of favor now, given that we actually mostly diagnose monogenic triglyceride disorders through next generation sequencing and panels. So one of the areas that sort of tends to be underdiagnosed is the so-called remnant hyperlipidemias. As a phenotypic guide, roughly that the triglycerides are equal to the cholesterol. Those are the kind of patients that you should have a degree of suspicion about. It's caused by variants. They're far too common to be called mutations. They're 1% of the population. So much of it is caused by being ApoE2 homozygote. They have an increased panvascular risks, increase between 4 and 9-fold. The prevalence is 1 in 50,000. So it's actually a subset of the prevalence of ApoE2 homozygosity, which is about 1%. And it is, again, an interaction of a gene defect plus environmental risk factors, plus possibly something else, which we don't actually understand. The significance of ApoE2 is that the management is slightly different to standard cholesterol disorders. You also have a remnant hyperlipidemia caused in ApoE4 homozygosity. That's far less severe. Triglycerides do rise, and there is here an allele-specific effect, but it actually relates to the dose of the allele that you're getting. The pathognomonic feature of remnant hyperlipidemia, which you see in severe cases, is triglyceride deposition in the dermis. And as that happens, you see yellowing of the skin, particularly around the palmar creases. Sometimes you can get sheet-like xanthomata, and those can occur either on extensor surfaces or they can occur even on the palms. They're one of the very few causes of palmar xanthomatosis. For very much higher triglyceride disorders, then you get this papular rash. Again, this is deposition of triglycerides, but not only in the dermis, but in the epidermis. And those are called eruptive xanthomata. They occur in pressure areas. So again, typically elbows, also across abdomen and buttocks. They tend to be associated with very much higher triglyceride levels. If you see a remnant hyperlipidemia, then you have an significant increased vascular risk, and that's across all vascular beds. With eruptive xanthomata, those tend to actually parallel the extreme hypertriglyceridemia, and the risks are of pancreatitis far more than they are of cardiovascular disease. So there have been a number of meta-analyses of this. This is probably the largest. And you can see that as you go from genotypes, you see this wide variation for ApoE2E2 in terms of the CVD risk. That's probably because we actually have a biallelic distribution in there. So you have the very high risk intermediate mixed with a lower risk group. But thereafter, you see this sort of uniform gradation across risk. And that's why it's important to measure the whole profile. Some laboratories still just report ApoE2E2 and don't report anything else. I think that's being a little bit conservative. ApoE404 is a defect of macrophage function and causes a direct defect in that. And macrophages are also microglia when they're found in the central nervous system. And there is a clear association with ApoE4 gene dosage with risk of Alzheimer's disease. So the odds ratio goes up between 6 to 12-fold depending on dose. The disease onset is about 2.5 years earlier, but the sensitivity and specificity as ApoE4 for the diagnosis of Alzheimer's is low. So that has been a recent controversial paper that's just come out in Nature Genetics, suggesting that there is a subtype of Alzheimer's disease, which is ApoE404 dependent, but that is a single publication at the moment. And at the moment, I think we have to sort of stick with the guidance that we've got, which is that there are uses for the ApoE genotyping across the spectrum for atherosclerosis, rather than actually being overly concerned about the Alzheimer risk. However, you don't need to do it in everybody with high triglycerides. In actual fact, it's a waste of money to do ApoE genotyping against high triglycerides. Because you have an increase in the amount of triglycerides per unit particle, One of the ways of getting a measure of this is to look at non-HDL. As I mentioned, it correlates with triglyceride levels, and compare that to ApoB levels. So here are a couple of algorithms from Newcastle and from Montreal that basically say that if you have a non-HDL over ApoB ratio of over 3.7 millimoles per gram, it's worth doing the test. If it's below that, it's the most likely form of hypertriglyceridemia, which is a polygenic inheritance with different genes, mostly to those that are found to cause elevated cholesterol levels, though there is some overlap. If you actually, this is the alternative group for Newcastle, uses beta quantification, i.e. ultracentrifugation, to give a second level of screening, but that may be a little bit too complicated. I prefer the first one. It's actually nice and easy and means that you only genotype those people that you need to, and therefore you minimize the risks of reporting ApoE4 alleles where you do not need to. The significance, as I said, is in cardiovascular risk terms, and because in this disorder, the ApoE2 binds less well to the LDL receptor, therefore you tend to get an increased prevalence of remnant lipoproteins in the circulation. They circulate for longer. They are more atherogenic per unit particle number. You get increased risk of vascular disease. So the trick in clinical terms is to actually increase processing of ApoE, and thereby you actually have to think about what's on the particles. These particles all contain ApoB as the principal ligand for the LDL receptor, but they also have the true triglyceride determining factors. So you have something, ApoE accelerates clearance of particles, and ApoC3 acts as a brake. And it's classical engineering. If you want a fast responding system, just as in a car, you have an accelerator and a brake. So if you have something that actually the accelerator is a bit stiff, which is what ApoE2 does, you'll have excess braking, you'll have excess particles left in the circulation, and excess risk. So how can you actually increase the speed of turnover? Well, you actually reduce ApoC3 levels. And we've had drugs that do that for years, and they're called fibrates. So this is one of the very few indications where fibrates remain indicated as a primary therapy. And we generally tend to treat these remnant hyperdemias with a low-dose fibrate and a low-dose statin, and that actually works for the vast majority. So what about the more severe end? People are becoming increasingly recognizing that high triglycerides are associated with pancreatitis as well as with new diabetes, as well as cardiovascular risk. And this is data from UK Biobank showing the increase in risk, particularly when you get up to levels of over 10 and over 20 millimoles per liter, or 10 of 1,000 or 2,000 milligrams per deciliter. And that is why virtually every single guideline that is written will say that triglycerides of over 20 needs to be reviewed by a specialist, and triglycerides generally over 40 or 50, particularly with abdominal symptoms, need to be treated as an acute emergency and referred for acute assessment in hospital. In the longer term, they always translate to new diabetes, and this is because pancreatitis leads to chronic pancreatitis, leads to beta cell destruction, so you have an increase in the risk that basically parallels that. Hypertriglyceridemia-induced pancreatitis also tends to be slightly more severe than pancreatitis caused by virus-related disease, which is generally the common cause otherwise, or alcohol-related pancreatitis, which without hypertriglyceridemia. And you can see the hospitalization duration is doubled. The intensive care admissions are doubled. They generally tend to be less obese. The triglycerides, you can see, tend to be about 1,300 milligrams per deciliter, 15 millimoles per liter, so a lot higher, far higher incidence of uncontrolled diabetes. And diabetes tends to be more difficult to control in these cases because the triglycerides increase insulin resistance. So actually, when you dose insulin acutely, you have to use higher doses to actually get some degree of control. So this leads me on to sort of the concept of chylomicronemia syndromes. And what is it in triglycerides that actually causes the problems? We have two classes of particle that contain triglycerides. We have the chylomicrons made in the gut in response to meals, and those contain apolipoprotein B48, which is made specifically in the gut. We then have triglycerides that are repackaged in the liver after being taken up from the circulating chylomicrons. Those are VLDL. They have a slightly lower triglyceride content. They have ApoB100. But the two particle groups behave differently in terms of pancreatitis risk. So chylomicrons are sticky. They will stick to anything. They will stick to the sides of tubes of plastic that are designed to repel anything else. They tend to coagulate, and therefore they will cause microcapillary obstruction. They are also, as they pro-atherogenic, and VLDL are less pro-inflammatory and pro-atherogenic. So what happens is that if you have excess chylomicrons, you tend to get more inflammation, you tend to get more disease, and that's the reason that you get more pancreatitis, more diabetes in the longer term. How can you tell how much chylomicrons there are? Well, ideally you do an ultracentrifuge, but that's not available to many of us in routine practice. Basically spin the sample. If you've got a nice little cream layer on top of the sample, which is absolutely white, and then a yellow layer below it, you know those chylomicrons. You actually don't need to know very much beyond that, because VLDL will actually always dissolve into the general plasma layer. Chylomicrons will always sit on top if you leave the sample there. So chylomicronemia syndromes, which are related to pancreatitis, most of them are actually polygenic. The single gene disorders remain moderately rare in them. So please remember that there are other gene hits. There are things like the monogenic pancreatitis syndrome. So PRSS1 is a monogenic pancreatitis-related syndrome. You can have immune-related disorders like IgG4 disease, which is associated with peritoneal fibrosis, and with pancreatitis, which also will markedly increase the risk. So please think beyond triglycerides. There may be other factors that you need to think about that are hepatology related to have caused that admission. We can have other causes beyond gut and liver factors. So lipodystrophy syndromes are associated with extreme insulin resistance. Some of them are not that clinically obvious, that you can have partial lipodystrophy syndromes that are quite subtle, and but nevertheless, they are different and they have a different mechanism of treatment. We have a few rare cases that are autoimmune, and there are antibodies that can be made to lipoprotein lipase, the enzyme that is involved in removing triglycerides and hydrolyzing triglycerides from both chylomicrons and VLDL. If that's deficient, you can't process the particles properly. If you lack the GPIHBP1, which is a binding factor for LPL and actually acts as the first line binding before these particles are taken up through either chylomicron receptors or ApoE receptors, then you will also get chylomicrons being preferentially left in the circulation. Those have a different management. They tend to be associated with autoimmune disorders, and there are case descriptions now of doing immune reset with rituximab therapy, which have been successful, and those appear. Some of them actually have resolved spontaneously. Personally, I recently had a case where it was actually associated with hypothyroidism, with hypothyroid goiter. The thyroid goiter was extracted, the chylomicronemia syndrome also resolved. So do think of it, it's a rare cause. The antibody assays, unfortunately, are not widely available. Currently, there's only one center in Japan that's doing them. But hopefully those centers, now that we've got anti-HMG CoA reductase antibodies for rare statin syndrome, statin-associated myopathy, we will also begin the immunology labs, and will begin supplying assays for these in due course. There is a final group that still occurs. It's mostly historical, in that there are children who are treated for cancer, particularly as neonates, with total body irradiation followed by bone marrow transplantation, and develop a secondary lipodystrophy. Those ones can also give a chylomicronemia syndrome, and they like some of the lipodystrophy syndromes, respond to lectin therapy because it's primarily a fat cell disorder rather than a lipoprotein lipase disorder. So what do chylomicronemia syndromes look like? There's, as I say, they vary between about 1 in 10,000 to 1 in 100,000. It depends exactly on which definition you use. They're associated with hypertriglyceridemia. They are sometimes associated with eruptive xanthomata, often with pancreatitis, particularly precipitated by viral infections. Luckily not COVID, but we have seen it with other viral infections in the past. Long-term riskers of type 2 diabetes, chronic pancreatitis, and they're all due to sort of, in the monogenic process, by defects, they're both all recessive disorders, so it's actually being homozygous for defects across the lipase, cofactors, controllers, or receptors. Homozygotes are rare, they're generally severe. Most cases present either neonatally or they present when during puberty, when either estrogens raise triglyceride levels or testosterone raises both. So you tend to have a peak of around 12, one discovery peak around age 0 to 1, and another discovery peak around age 10 to 14. They have recurrent pancreatitis, sometimes even on moderate triglyceride levels, because it's the chylomicrons that cause the damage, and it's a matter of how much is in the chylomicrons. Heterozygous are far commoner. The triglyceride levels tend to be a little bit higher. The onset is actually postponed into middle age, often associated with secondary risk factors, weight gain, alcohol, diabetes, and they tend to have a far lower incidence of pancreatitis, 1 or 2 events. So it's usually an acute presentation. You can manage them and they have very low chance of recurrence. That's not true for the homozygotes. Generally, as I said, anyone with triglycerides over 2,000 and acute abdominal pain is an emergency and needs to be seen. Please remember that triglycerides and cholesterol rise in the third quarter and third trimester of pregnancy, and hypertriglyceridemia in pregnancy is an obstetric emergency and needs to be, 1, recognized and 2, treated. So always measure triglycerides in pregnancy in third trimester in anyone that has a history of family history of diabetes or a family history of pancreatitis. As I've mentioned, we have autoimmune chylomicronemia syndromes, and this is sort of just the original description of them, showing that you have a recovery of the GPI-HBP1 with the antibodies and response to, and that these actually inhibit the response to treatment. What about treatment? Triglycerides, as I said, please treat non-HDL in the first instance. It doesn't matter how you do it. Non-HDL responds to statins, first line. Fibrates are third line. Niacin is basically not used anymore. And we will use specific omega-3 preparations as per indications. For fibrates, most of the data is in monotherapy. There is little data for fibrates added to statins. The main trials have been negative or null. And as I said, I would say that there's probably the only indication now is remnant hyperlipidemias. We would basically treat through LDL reduction as the primary mechanism in most people, unless the triglycerides are particularly high or there's a remnant hyperlipidemia. The reason for that was the prominent trial, which followed the Accord trial in showing no benefit of additional triglyceride reduction in people with type 2 diabetes and an original triglycerides of around 250 to 300 milligrams per deciliter. So it might be a slightly different story at higher levels. The other newer option that we have, or actually a traditional option that we still use in pregnancy, is omega-3 fatty acids. So these are drugs like Omacor, which is an equimolar mixture of DHA and EPA. And these days we have more modern forms like icosapent-ethyl, which is pure EPA. Basically a dose-dependent response in triglyceride reduction, probably acting directly at the level of VLDL synthesis in the liver and in the enterocytes in the gut. There are specific receptors for omega-3s. It's known as the FFAR4 receptor, and that's related to both anti-inflammatory effects and also to insulin sensitization through the GLUT4 glucose transporter. and also affects bile acid conjugates. The omega-3 trials for CVD are complex, but there's a simple message. One is low levels of omega-3 make very little difference. You need to use 2 to 4 grams, especially of EPA. Bit of a controversy about whether DHA actually has an effect. When we come to the monogenic hypertriglyceridemia syndromes, then we're going to sort of look at these are orphan disorders. They have an incidence of 1 in 50,000 to 1 in 250,000. They're monogenic, generally recessive. There are a number of options for treating them, and I'll go through those briefly. There are microsomal transfer protein inhibitors. Those stop the loading of triglycerides onto ApoB particles, both in the gut and the liver. Very rare indication. We don't use that much. ApoC3 inhibitors are actually probably our therapy of choice, and there are others that are in development or are being looked at. Lomitotide therapy, inhibitor of microsomal transfer protein, stops loading of particles. There is a dose proportional triglyceride reduction. Basically, all the data is based on single case reports. The problem with lomitopide is that it causes dysfunctional liver tests, and there have been cases of hepatic fibrosis. So it's not used very often, but there are case descriptions of its use. What we're mostly using in monogenic triglyceride disorders is volanesorsen, ApoC3 inhibitor, administered 2 weekly, very effective in terms of reducing triglycerides, 75 to 80%. Pancreatitis reduction, probably in the region of 50%. The data is a little bit woolly on that, but nevertheless, very effective. Problem with original version of volanesorsen, which is what we've got, is it requires platelet monitoring, and it can drop platelets. Those tend to respond to stopping the drug and then restarting, and then you can restart later. Newer versions of volanesorsen, which are the GalNAc derivatives, which reduce the dose, increase liver-specific targeting, actually have far less platelet effects while maintaining the triglyceride reduction effect. Those are due to be licensed in the near future. The other way we can deal with homozygous lipoprotein lipase disorders is to look at ANGPTL3 inhibition. This is an ancillary regulator of lipoprotein lipase. So therefore, if you have no lipoprotein lipase, it probably won't work. And that is the data that has actually been shown, that if you take an antibody to ANGPTL3 in case of ivanacumab, in the cohort that have no functional lipoprotein lipase activity, it doesn't work. In the people that are heterozygotes, it works, and it works in polygenic disease. So at the moment, we have an antibody, ivanacumab, is licensed for homozygous familial hypercholesterolemia to reduce cholesterol, but it also reduces triglycerides, and we will probably be using it in that indication, at least in multifactorial chylomicronemia in some cases. Whether ANGPTL3 antisense goes any further remains to be seen. There was one developed. It wasn't much better than fibrates. It caused a little bit more and wasn't particularly effective. So we'll see whether actually those continue in development. The final thing that you can do, and this is rather historical, but I pretty much suspect it will come back again, but with a different vector, is that we have got gene therapies. We're beginning to look at gene therapies for monogenic familial hypercholesterolemia. That's knocking out PCSK9 with CRISPR-Cas9 and then so if you don't have a PCSK9 defect, LDL receptor defect, treating as you would with a. For alipogene, this is actually an add-in therapy. So you're not knocking out a gene, you're trying to add in a gene and actually promote function. And here they were adding a slightly hyperfunctional variant of lipoprotein lipase, and that did actually deliver a reduction in pancreatitis episode. The triglycerides came down transiently. That was chylomicrons, but they came back up again as it rotated, as the particle lipid distribution rotated to VLDL. This was discontinued for commercial reasons. And secondly, it was discontinued because the efficacy wasn't that great. So I think we'll come back to that. We're going to need a slight development in gene therapy. In the long term, this is how we're going to treat those patients. So how do you manage with them at the moment? We have got algorithms for treating hypertriglyceridemia, and this is the kind of algorithms that we use. So Radha and Dr. Ramachandran is going to talk about these in a little bit more detail. but hypertriglyceridemia protocols do exist, and you can follow this kind of algorithm as whether they're diabetic or non-diabetic, and what drug treatments there should be, and how much extra, and whether you should actually use physical removal techniques for triglycerides such as plasmapheresis. So in conclusion, triglycerides confer CVD risk. That's through their role in raising non-HDL, and non-HDL should be the maximum treatment. Triglycerides confer risk of new diabetes. Again, weight loss and data are going to be there. And there's always a risk of pancreatitis. So be very careful with GLP-1 drugs with people with previous pancreatitis and high triglycerides. They are not the therapy of choice. Extreme triglycerides are treated with chylomicronemia syndrome and pancreatitis. They're a lipid emergency. Most are multifactorial, and standard protocols will manage most cases. You may need plasma exchange acutely, and a few of patients with monogenic chylomicronemia syndrome require orphan drug therapies. Thank you very much.
Thank you. Thank you very much, Professor Wierzbicki. A couple of questions in there. So the first one of them is around safe levels of triglycerides if we're aiming to initiate GLP-1s, recognizing that some individuals may be at risk of pancreatitis as a result of being a GLP-1. Is there such, are there any data around?
I don't think there's any really good data. Most people, I think sort of there's a rough clinical consensus that triglyceride levels below 5 with an absence of risk factors, you're probably going to be relatively low risk.
5 millimoles.
It's about 5 seems to be where the risk markedly increases in the Copenhagen Heart Study and in Biobank.
Thank you. And do you have any comments on Omicron and the risk of atrial fibrillation?
The story about atrial fibrillation with high-dose omega-3s has been around for a long time. Like the GI disturbance, this has sort of basically got higher prominence since the trials have come out. Again, it's a matter of precipitating. It's like statins and diabetes. You are precipitating an event that was likely to happen. So just like statins tend to bring forward the incidence of diabetes by about maybe 15 to 18 months in people who are going to develop it anyway, people who are at risk of developing atrial fibrillation, it just brings it forward. The absolute levels of risk in the trials were quite low. There wasn't a huge numbers, but because the relative risk was increased about 5-fold, all the regulators have taken this on board and therefore put it in the label, mostly to get people just to look out for what other factors there might be that precipitating arrhythmias. And though the classic two that we have are alcohol and excess caffeine, depending on the society you come from.
Of course. Thank you. Thank you very much. It's been really informative presentation, and thank you very much. Hand over to Amir.
Thank you very much. For the next session, I'm delighted to introduce Dr. Radha Ramachandran, who's a consultant at Guy's St Thomas Energies Foundation and Ori Clinical Senior Lecturer.
Good afternoon, and many thanks indeed for inviting me to do this talk on lipid disorders in pregnancy. For this talk, I've divided my talk into 3 parts. In the first instance, I'm going to discuss the physiological changes in lipid metabolism in pregnancy, then on the impact of pregnancy outcomes, and then the principles of management. But before I do that, I think it's important to reiterate the importance of cholesterol and on fetal development. So the lipids and cholesterol are vital for meeting the higher energy demands of the growing fetus. It's important for placental growth. It's vital for embryonic organ development. It's important for fetal neurodevelopment, and it's also important for supply of essential fatty acids. As we know, essential fatty acids cannot be synthesized de novo by the fetus, and therefore it relies entirely on maternal transfer and biomagnification. And if there is a problem with this transfer, either due to the placenta or due to maternal dyslipidemia, then it can result in congenital malformations. So cholesterol is not only important as a structural component and an energy source, it's also important as a precursor for important compounds such as steroids. Cholesterol sources are endogenous, that is, so cholesterol that's produced in the fetus, but it relies significantly on exogenous sources from the mother. So what are the physiological changes that happen in lipid metabolism in pregnancy that enable enough cholesterol transfer for the baby? So we need to look at pregnancy in two parts. The first phase is the anabolic phase, which is in the first and second trimester. This is an insulin-sensitive phase relatively, and this phase, along with the increase in progesterone, cortisol, and prolactin, results in lipogenesis and also in uptake and storage of fat by the adipocytes in preparation for the increased demands from the fetus later on in pregnancy. The third trimester of pregnancy can be considered as a catabolic phase and a relatively insulin-resistant phase. And this phase is associated with increased lipolysis and hypertriglyceridemia. So this graph very nicely depicts the changes in the lipid profile in pregnancy. It was published in the American Journal of Obstetrics and Gynecology in 2017 by Wierzbicki et al. On the x-axis, you can see the months from conception. It starts from 1 year before conception until 1 year after, with the two gray lines highlighting the point of conception and delivery. The pink line is the total cholesterol, black is triglycerides, green is LDL, and red is HDL cholesterol. And as we can see, all of these levels rise during pregnancy, with the steepest rise occurring in triglycerides. So total cholesterol and LDL rise by 40 to 50%. Triglycerides rise 2 to 3-fold. The ratio of LDL and HDL remains unchanged during these physiological increases. And the LDL and HDL in pregnancy are triglyceride enriched versus in the non-pregnant state. There is a greater proportion of large HDL and small LDL. There's also a concomitant increase in relevant apolipoproteins, and there is an increase in lipoprotein (a). However, despite these increases, normal pregnancies are most often associated with total cholesterol levels less than 6.5 millimoles or 250 milligram per deciliter. And when women with abnormal pregnancies are included in the cohort, such as with GDM or preeclampsia, the levels are often above 7.75 millimoles per liter. So what is the impact of dyslipidemia on maternal and fetal outcomes? I think the first thing to say is that evidence generation in pregnancy is harder because of the strict restrictions around research in pregnancy, and also because of the risks associated with for the fetus and medical legal concerns. And therefore the evidence is limited, and it's certainly there isn't enough evidence to have treatment or intervention thresholds as yet in dyslipidemia in pregnancy. But there have been a number of studies that have been done, and they've looked at fetal comorbidities, including large for gestational age and preterm birth, and high triglycerides and low HDL have an increased risk of large for gestational age and preterm births. In terms of maternal comorbidities, if we look at cardiovascular risk and then we look at risks of GDM and preeclampsia, number of risks parallel cardiovascular risk, and therefore it is no wonder that a number of studies have looked at lipid profiles and dyslipidemia and its association with maternal comorbidities like gestational diabetes. This was a systematic review and a meta-analysis published in 2022 by Habibi et al. And it looked at maternal metabolic factors and the association with gestational diabetes. It looked specifically at hypertriglyceridemia as well in this paper. It was 13 cohort and 3 nested case cohort studies. The number of participants ranged between 107 and 15,000, and fasting triglycerides were done before 16 weeks. And the results for hypertriglycerides and its association with GDM are published in these two forest plots. The first one is looking at the odds ratio of developing GDM with every unit rise in triglycerides. And the second fluorospot B is looking at the odds ratio of developing GDM with triglycerides greater than 1.17. So higher triglycerides were associated with a higher risk of GDM. As you can see, it reached quite a high significance. Meta-analysis included 6 studies, and here triglycerides of greater than 1.7 millimoles per liter and HDL of less than 1.3 millimoles per liter were associated with odds ratio of 1.92 and 1.27 respectively. They were adjusted for maternal age and BMI. No association was found with total cholesterol and LDL. So looking at preeclampsia, it's not uncommon. 5 to 8% of pregnancies are affected by preeclampsia, and we know that preeclampsia results in a 2 times higher risk of cardiovascular disease in later life. Again, a number of studies have looked at dyslipidemia and preeclampsia, and high triglycerides, high total cholesterol, and low HDL increase risk of preeclampsia. LDL cholesterol, the association is equivocal, with a number of studies reporting raised levels and others reporting lower levels. So lipid screening currently is not part of routine antenatal care, and there are no treatment interventions or targets in pregnancy. So management of dyslipidemia in pregnancy is not included currently in any of the guidelines. The exception, of course, is hypertriglyceridemia, and that is severe hypertriglyceridemia. So this has been discussed in the whole lecture previously by Professor Wierzbicki, so I'm not going to go into too much detail, except to say that patients with FCS and MCS are at an even more risk of hypertriglyceridemia and dangerously high hypertriglyceridemia that increases the risk of pancreatitis and preterm labor. Therefore, these patients need to be managed very aggressively and very closely in pregnancy to ensure that the levels remain as low as possible. Levels above 20 to 25 millimoles per liter are extremely high risk, and we would try to ensure that the levels remain below this at all times in pregnancy. So the mainstay is very low fat diet, and by that I mean fat of less than sometimes 10 grams, sometimes 3 grams of fat. This is a very restricted diet, and if the women also have impaired glycemic control, which they might do, then the diet becomes even more restrictive. And the challenge is providing enough calorie intake, providing satiety and nutrition, keeping the fat at these very, very low levels, and also keeping an eye on the carbohydrates, because too much of carbohydrates can also cause further rise in triglyceride levels. Therefore, we rely significantly on a high protein diet. We will include medium chain fats to help with calorie and fats, and we would supplement with fat-soluble vitamins and other multivitamins that might be missing from the diet, and also, of course, essential fatty acids. But more often than not, these patients will end up requiring therapeutic plasma exchange, some as often as every alternate day or or 2 times a week, starting from the second trimester until delivery. There are treatments that we use as adjunctive treatments to therapeutic plasma exchange and very low fat diet, and this includes omega-3 at high doses. As to how effective it is in patients with familial chylomicronemia syndrome is unclear, but it does nevertheless provide a source of essential fatty acids for these patients. We do use fibrates as well. Animal studies have shown that there's no risk of congenital abnormalities, and therefore we would consider starting it in the second trimester, particularly in women where triglyceride levels remain greater than 10 millimoles per liter and where we are concerned about the risk of pancreatitis. Well, in this also, and you've again heard about the antisense oligonucleotide. Animal reproduction studies have shown no harm, and it is currently not recommended for use in pregnancy. However, we have recently presented or published 2 cases. One case was looked after by our co-authors and colleagues in Birmingham. She was a lady who was unaware of her pregnancy until 36 weeks, and she continued velenosaucin throughout this period. She delivered normally and a normal baby, and most importantly, did not require therapeutic plasma exchange during the pregnancy. The second case was managed at our center. She was on velenesorsen pre-conception, stopped before conception until her second trimester. Her triglyceride levels became very difficult to control. We discussed the pros and cons with the patient and started velenesorsen towards the second trimester, 22 weeks. However, she developed acute pancreatitis very soon after that and had to go on to regular therapeutic plasma exchange until delivery, and therefore it is unclear as to what impact velenesorsen has had on her pregnancy, as it is unclear how much was available given the regular therapeutic plasma exchange. Niacin, as you know, is not for use in pregnancy. So then we come on to the second group of patients who would more commonly present, and those would be pregnant women who already have pre-existing atherogenic dyslipidemia. Now, historically, in these patients, the advice would be to pause drug therapy before conception and until the breastfeeding has stopped. But the pausing drug therapy in these patients has consequences. Obviously, the lipid levels will rise to pre-treatment levels. Secondly, given that these patients would have stopped the lipid-lowering therapy pre-conception and then throughout pregnancy and then until after breastfeeding, and if they've had multiple pregnancies, that would mean several years off lipid-lowering therapy and therefore a significant increase in lifelong risk in cardiovascular disease. The fetal outcomes are no different, but maternal outcomes suggest that there might be a high incidence of maternal hypertension. So let's look at the evidence for lipid-lowering drugs in pregnancy. We'll start with statins. Obviously, they're the most commonly used. Almost all guidelines suggest to stop statins 2 to 3 months before conception or as soon as pregnancy is known, and then pause until after breastfeeding. And this was based on a 2004 paper that showed case reports of early exposure to statin resulting in fetal malformations. However, there have been a number of other reports that have been published that challenge that. And in July 2021, the FDA removed its strongest recommendation against the use of statins during pregnancy. Now, not all statins are equal. So pravastatin is hydrophilic and is metabolized differently to some of the other statins. It has been suggested to be safe in pregnancy and in fact was evaluated as a treatment for preeclampsia prevention when used early in pregnancy. The evidence for pravastatin and preeclampsia is equivocal, but what we do know is that pravastatin is actually safe in pregnancy, and therefore in patients with high risk, following discussions with the patients, there may be a case for continuing statins, particularly second trimester onwards. Bile acid sequestrants, the evidence for safety in pregnancy is limited, but it is not systemically absorbed and therefore is considered safe for use in pregnancy. It can lower LDL levels. However, it's important to remember that it may raise triglyceride levels and it may also decrease fat-soluble vitamin absorption. Ezetimibe, there have been animal studies which suggest that it crosses the placental barrier, and skeletal abnormalities were noted in some rabbit and rat studies. Therefore, it's not recommended for use in pregnancy and lactation, and the advice is to pause before conception. PCSK9, again, the data is limited, currently not recommended for use in pregnancy. Monoclonal antibodies are unlikely to cross the placenta in the first trimester, but may do so in the second and third trimester. Inclisiran is interesting because of the infrequent dosing. There may be a case for giving a pre-pregnancy dose that will help to maintain levels through pregnancy. Data is limited. However, there have been animal reproduction studies and they have shown no harm. Bempedoic acid, again, no data is available in pregnancy. Animal reproduction studies show no teratogenicity, and because of its mechanism of action, it is not recommended for use in pregnancy. Nimitabide, we know that that causes fetal toxicity and it is contraindicated in pregnancy. Evanacumab, no data available. Animal studies suggest possible harm, crosses the placental barrier and therefore not recommended for use in pregnancy. So what do we do with the patients who have got pre-existing dyslipidemia? We know that fetal outcome is no different to normal pregnancy. So the risks are mainly maternal risks that we are dealing with. Patients with homozygous FH obviously are at a very high risk of cardiovascular disease. And if they are getting regular apheresis, they should continue on that. And there is a strong case for continuing on the statins in these patients. Heterozygous FH patients and other patients who are at an increased risk of active stroke or at a high risk of stroke or cardiovascular disease, again, there should be a consideration for continuing the statin in these patients. I'm going to end with talking about some other orphan lipid diseases. I'm not going to talk in any great detail, and I'm not going to talk about all of them. But what I do want to reiterate is that a number of these conditions have very specific treatments and very specific considerations that need to be looked into during pregnancy. Some of these might require specialist birth plans that will allow management during pregnancy and labor, and also give recommendation for follow-up and management of babies. And these patients, because of the rarity of the case and because of specific nutritional and follow-up needs, should be followed up in a center that has expertise in managing these patients. So one of these conditions is A-beta lipoproteinemia. These patients have very low levels of ApoB, as a result of which they have very low LDL levels. And because fat-soluble vitamins are carried through the lipid particles, they are at risk of very severe fat-soluble vitamin deficiency. They often present with retinopathy, neurological deficit, and fatty liver and cirrhosis. And they are managed with supraphysiological doses of fat-soluble vitamins. Accurate vitamin status, particularly for E and A, are very difficult to determine, as again, these are carried in lipid particles, and therefore the lipid levels influence how the circulating levels are measured. Management usually involves low-fat diet, essential fatty acids replacement, and large doses of fat-soluble vitamins. And in these patients, they will need to be followed up in pregnancy to ensure they're getting adequate levels of vitamins, but at the same time to ensure that the levels are not so high that it is causing fetal toxicity, particularly vitamin A toxicity. Also important to remember that their babies will be heterozygote and therefore have hyper-beta lipoproteinemia, and therefore they carry a lifelong risk of fat-soluble vitamin deficiency and hepatic steatosis, cirrhosis, and in some cases HCC, and therefore will require lifelong supplementation with fat-soluble vitamins and also surveillance. Another such orphan lipid disease is cytosteroremia. We think it is underdiagnosed because the presentation is very similar to severe heterozygote FH, often with xanthomas and increased cardiovascular risk. It results due to mutations in the ABC transport proteins and results in increased absorption and decreased excretion of plant sterols. So treatment is usually a low sterol, low cholesterol and low-fat diet, and ezetimibe that it prevents absorption or reduces the absorption of plant sterols. And management includes a very specific low-sterol diet, which often contradicts the Mediterranean diet and dietary advice that is healthy heart dietary advice that is given for normal cardiovascular risk disease. So because there are not many treatment options in these patients, and stopping ezetimibe often increases plant sterol levels. Again, these patients need to be supported quite closely during pregnancy to ensure that the diet is optimal to prevent as little a rise on stopping ezetimibe as possible. So I'm going to stop there, and I'll be very happy to take any questions.
And yes, excellent. Yeah. Okay, so there is a couple of questions in the chat. The first one is about the role of insulin to activate lipases in severe hypertriglyceridemia in pregnancy. Do you want to comment on that?
Yeah, sure. So we would use insulin in severe hypertriglyceridemia more in the acute stage when if the pregnant woman is admitted to the hospital with acute severe hypertriglyceridemia, then we would use a fixed rate insulin infusion with glucose to maintain the levels. We wouldn't normally use insulin outside in the outpatient setting, particularly if there is no evidence of hypoglycemia, just because of the risks associated with it. So the standard protocol for managing hypertriglyceridemia in hospital is a fixed rate insulin infusion along with dextrose to bring the triglyceride levels down.
Thank you. And can you summarize the statins in pregnancy? Can you ever use them? Which ones? I know you mentioned it, but there's a question about.
Yeah. So technically, the guidance is to avoid them in pregnancy and actually avoid them before conception, 2 to 3 months before conceiving, and then throughout pregnancy. However, as I mentioned, pravastatin has been shown to be safe in pregnancy, and therefore they could be used in pregnancy, particularly in women who are at higher risk. So the guidance, the FDA guidance, continues to be avoidance of statins, but it can be used at the discretion of the clinician and on close discussion with the patient, particularly if the risks outweigh, the risks of cardiovascular risks are quite high. So we could, for instance, use pravastatin or sometimes a low dose of rosuvastatin, particularly in the second trimester of pregnancy. But again, it should be discussed with the patient and a consensus reached, really.
Thank you very much. And one last question before we move on. Cardiovascular risk reduction with bile acid sequestrants. Is that been approved? What's the evidence?
So bile acid sequestrants are safe in pregnancy and they can be used. I haven't used it very often at all in pregnancy for reducing cardiovascular risk in patients.
Okay, thank you very much again. Really great talk. In the interest of time, I'm going to move to our final speaker, Dr. Jaimini Cegla, who's a consultant in metabolic medicine and leads the Lipids and Cardiovascular Risk Service at Imperial. Jaimini, it's a pleasure to have you.
And thanks so much, Amir, for the invitation today. As Amir said, I'm Jay Cegla. I look after the Lipid service at Imperial College Healthcare. I work at Hammersmith Hospital, which you can see here on the top right-hand side of that picture. And today I'm going to talk about lipoprotein a, or LP a for short. And hopefully over the next 20 minutes or so, I'm going to convince you that LP a has arrived as a cardiovascular risk biomarker, and we should be using it to really evaluate our patients properly for their cardiovascular risk. And secondly, I'll be discussing some of the emerging sort of evidence of LP a as a therapeutic target. And here is sort of the format of the talk. I'm going to be talking about LP a and cardiovascular risk, in whom we should be considering measuring LP a, some of the treatment avenues that we have available, and some of the potential further research aspects that we should be considering. So we'll start off with this case, and this is a really typical sort of case that we would see in our clinic at Hammersmith Hospital. And this is Mrs. K. She's a 57-year-old lady, and she's got a history of fibromyalgia, but she's also had a PCI to her LAD in 2022. And you'll look at her medications and you'll think, gosh, why isn't she on atorvastatin 80 milligrams? And unfortunately, she's been limited because of her fibromyalgia, and she's only on the 20 milligrams of atorvastatin. We look at her family history, and you can see it's pretty noisy there. Her father had an MI at the age of 59, and her brother has also had a PCI at age 62. She's a non-smoker. Her blood pressure probably needs a little bit of optimization there. BMI is 24. Now, if we look at her lipids, her LDL is probably not optimized adequately. But there's nothing there that really sort of makes us understand what has really been driving her cardiovascular risk. Why did she have such an early event? And so this is exactly the sort of case where we would think about measuring LP a. And this is what we've done. And hers came back at 355 nanomoles per liter. So what does that mean? If we put that into context, if we look at the EAS, the European Atherosclerosis Society guidelines, 125 is their sort of risk threshold, their rule in for risk due to Lp(a), and that equates to about the 83rd percentile for the general population. And so this lady has exceptionally high Lp(a) levels, and this would be sort of the 99th percentile, so very high. And this is really helpful because it really helps us explain why she has had this premature event in her. And Lp(a) is different to LDL in that it is predominantly genetically determined, so more than 90% genetically determined. And if we look at Miss K's family here, we've got her family tree drawn out, and she's here just marked by this green arrow. You can see she's got these very, very high levels. And we look at her parents. Unfortunately, we don't know their Lp(a) levels. We can look at her siblings. So her brother also has a very high Lp(a) concentration. He, remember, had that PCI at age 62. But her unaffected sister, no CVD in her, has very normal Lp(a) levels. And then she's got two kids who have been sort of proactively had them measured, and you can see that their levels are also pretty high. And the pattern of inheritance here is autosomal codominant. So you inherit your levels from both mum and dad. And on the right here, we've just got her distribution of Lp(a), in the general population. This is from the Copenhagen study. And you can see both in men and women, the distribution is very similar. And most people have these pretty low levels of Lp(a). And then you've got this tail, this long tail in red of those higher concentrations. So just delving a little bit more into the genetics now. Lp(a), as I said, is predominantly genetically inherited. And if we look at the structure in a little bit more detail, it looks very much like LDL in that you've got this small quite small, dense lipoprotein, and it's wrapped around in this blue ribbon, which is the ApoB. And then different to LDL is the fact that it contains apolipoprotein a. And here you can see this in these blue and red circles here. And apo(a) contains this one section called the Kringle 4 type 2 domain. And this basically really determines the concentration of your Lp(a) in your blood. This is the predominant determiner. And if you have a small ApoA allele, so you've only got a few of these repeats in this little red section, then you tend to have higher concentration. And if you've got a large ApoA allele, then you tend to have lower concentrations. And so we can do studies like Mendelian randomization studies, where we can look at Lp(a) increasing genetic variants. And what we see is that there is a strong association with high Lp(a) concentration in the blood, but there's also a strong association with cardiovascular disease risk. And because this is Mendelian randomization, this is Lp(a) genetic variant, so with you since birth. This is a bit like nature's kind of clinical trial, and this tells us about a causal relationship between that high Lp(a) and the cardiovascular disease. And you can see this not just in the Mendelian randomization studies, as it's seen here on the left from the Copenhagen group. You can see this relationship not just for MI, but also for aortic valve stenosis, and less strongly, but also there for ischemic stroke and heart failure. But also from studies looking at the epidemiology. So for example, the emerging risk factors collaboration. This is a meta-analysis of 14 epidemiological studies that showed that the higher your Lp(a) concentration, the higher your cardiovascular risk. And so in 2019, Heart UK put together a consensus statement, and we looked at this risk and tried to sort of categorize it in terms of the cardiovascular risk that the Lp(a) confers. And so on the left here, you've got Lp(a) concentration in nanomoles per liter increasing here, and the impact of cardiovascular risk identified as minor, moderate, high, or very high. And this relates also to the percentile of the Lp(a) in the general population. And it's important to understand that actually across different ethnicities or ancestries, your Lp(a) concentration does distribute differently. So in white individuals, it's very much as I showed you in that Copenhagen data. This is actually from UK Biobank, but if we look specifically at white individuals here in panel A, you can see that it's exactly that same distribution. A lot of people with very low levels, and then you've got this long tail of higher concentrations. However, if we look at data from Biobank looking at Black individuals, you can see that distribution is different. You've still got most people with these lower levels, but you can see that it's much flatter in its distribution. However, in terms of cardiovascular risk, it's very similar. So as the Lp(a) concentration increases, you can see that the cardiovascular risk also increases. So this risk is pertinent to all different ancestries. So how does Lp(a) confer this increased cardiovascular risk? Well, as an LDL type particle, it's proatherogenic, and it's even more liable than LDL to get into the arterial wall, cause that smooth muscle cell proliferation, and increase that lipid-rich necrotic core within the plaque. At least in in vitro studies, we've seen data to suggest that it is prothrombotic, and this links back to this apolipoprotein a. Apo(a) has quite a high sequence homology with plasminogen, and it's thought to impact fibrinolysis. And as I said, in vitro, it seems to reduce plasminogen activation and increase platelet activation. So it's a double hit. It seems to be proatherogenic and prothrombotic. But additionally, it is pro-inflammatory. So a large number of oxidized phospholipids reside on Lp(a), and there's increased monocyte trafficking and cytokine release associated with this. And this is just some data from about 8 years ago now from a Dutch group that looked at the impact of Lp(a) on arterial wall inflammation. And this was using FDG PET, and they showed that there was increased uptake of FDG within the carotid and aortic arteries with increased Lp(a) levels. And additionally, there was increased monocyte trafficking within the arterial wall. So coming back to Miss K, what would have happened if we'd known about her Lp(a) prior to her event? If we'd known that they were exceptionally high, would this have impacted our management? And you know that, the usual risk calculators that we use, like SCORE and Q-risk, they don't have Lp(a) as part of them. There is now, developed by the EAS, this Lp(a) clinical guidance risk calculator that's been devised based on UK Biobank data. And I'm just going to show you a few snippets of this because I find this very useful in clinic. And so for Our Lady, for Mrs. K, if we looked at her risk, it's seen here in blue, without her Lp(a), this is her cardiovascular risk of having an event up to the age of 80. And this worked out at 17% for her. However, if we included her Lp(a) concentration into that, you can see that her risk goes up to 40%. And so knowledge of this may have really impacted her management, because it may have made us start prevention at an earlier stage. And what I really like about this calculator is that you can look at what the impact of intervention would have had on her risk. And so on the right side of this graph, you can see, on the right side here, you can see that lowering her LDL by 1.2 millimoles per liter and her blood pressure by 10 millimeters per mercury would have lowered her risk to 23%. Okay, so that's cardiovascular risk and Lp(a). In whom should we measure Lp(a)? Now, the international guidelines are all moving towards measuring Lp(a) at least once in a lifetime in all adults. So talking about screening, sort of universal adult screening for Lp(a). And so the EAS, the European Society of Cardiology, they talk about at least once in an adult's lifetime to identify those at very high Lp(a) levels, so more than 430 nanomoles per liter, which is pretty much equivalent to a lifetime risk that's similar to someone with heterozygous familial hypercholesterolemia. The National Lipid Association in the US have just updated their guidelines again to recommend all adults having their Lp(a) levels checked, and then specific cohorts within the pediatric population as well. And the same goes for the Canadians. Once in a lifetime is what they have recommended. When we did our consensus statement in the UK back in 2019, we didn't feel that we were in the right position to be recommending Lp(a) as a universal test for all people. So we specifically decided to focus on 5 cohorts of people who we thought would benefit most from knowledge of their Lp(a) concentration. And that was people who had a personal or a family history of premature cardiovascular disease, those with a first-degree relative who had an Lp(a) concentration that was very high, so over 200 nanomoles per liter, those with a genetic dyslipidemia, people with calcific aortic valve stenosis, and I'll come to this in a bit more detail on the next slide, and those with a borderline increased 10-year risk of a cardiovascular event. And this is because knowledge of the Lp(a) may make you more likely to start treatment with a statin earlier, as you can see that there's increased risk because of the Lp(a). So looking at the story with Lp(a) and calcific aortic valve stenosis, this is data from the Astronomer trial, and they looked at people here in the red here. This is the highest tertile of Lp(a) concentration. And you can see that their progression rate of aortic valve stenosis was higher than those people with those lower levels. And additionally to this, here in panel C, you can see that those in that highest tertile had an event rate, an event-free survival of requiring intervention. So they required intervention for their aortic valve at an earlier stage than those who had lower Lp(a) concentrations. So it follows that actually, if you know about the Lp(a) concentration, that may impact your surveillance interval. Moving on to treatment. What treatment options do we have available to us? So actually, currently, there are no approved pharmacological therapies for lowering Lp(a). These are in development, and we'll talk about these in a little bit more detail. But what can we do for our patients today? So what about using aspirin? Can we mitigate some of that prothrombotic risk by using aspirin? I'll show you some of the data for that. What about using statins to lower the LDL and mitigate some of the that proatherogenic risk through LDL lowering? What about PCSK9 inhibitors? We know from the clinical trials that the MABs and the siRNA-based treatments lower Lp(a) modestly by about 10 to 25%. So can we use these to mitigate some of the risk? And what about apheresis, by physically removing the Lp(a) from the blood circulation? So these are the 4 strategies I'm going to be considering in the next few slides. So aspirin, can we mitigate that prothrombotic risk using aspirin? And the earliest data that we have looking at this question is from the Women's Health Study. And they looked at people who are carriers and non-carriers of this SNP that raises Lp(a) concentration. And they looked at people here, you can see in this dashed line, these are people with the highest Lp(a) who received placebo. And you can see that their MACE event rate was higher than the other groups. So this was in the placebo. However, those patients who were carriers of the Lp(a) SNP but received aspirin, you can see that their risk was attenuated, and it was to the same level as non-carriers of the Lp(a) SNP. So that is this is data that's retrospective, sort of a post hoc analysis looking at this question. So this RCT obviously wasn't designed to answer this question, but it does give us a suggestion that actually mitigating some of the risk of Lp(a) using aspirin may be beneficial. And more recently, we've got data from the Esprit trial. So this was using aspirin in primary prevention in the elderly. And you can see in the placebo arm, those who had higher Lp(a) here in red had a higher event rate. However, in the aspirin group, you can see that this was attenuated, or even slightly lower. So again, very suggestive that that aspirin may be of benefit in people with high Lp(a). What about reducing the residual risk due to raised LDL in these patients. And this is data from an angiographic study from Steve Nichols. And if we just focus on this panel C, looking at MACE event rates, and we look at people with the highest LDL concentration here, above 2.6, you've got people in white here with the high Lp(a). You can see that their risk of MACE was higher than those with the low Lp(a). However, when you get to people who are achieving LDLs of less than 1.8, you can see that the risk of the high Lp(a) is attenuated. So this suggests that actually, if we lower the LDL cholesterol enough, we may be able to mitigate some of this risk. So what about using PCSK9 inhibitors? And do patients who have high Lp(a) have greater benefit from the MABs? And here we've got data from the Fourier trial and the Odyssey outcomes trial. So both phase 3 cardiovascular outcome studies that looked at PCSK9 monoclonal antibodies. And again, as a post-hoc analysis, these data were stratified for Lp(a) concentration. So we focus on Fourier here on the left. You can see people with low Lp(a) on the left and higher Lp(a) on the right. And if we look at the higher Lp(a) group, you can see that those who had placebo in blue had higher absolute risk. However, compared to their counterparts who were having placebo and had low Lp(a). And you can see that the absolute risk reduction in those with high Lp(a) was greater. And whether that is because they're at a higher absolute risk in the first place, or whether it's because they have greater benefit because of the Lp(a) lowering, it's really difficult to tease out. But certainly they did seem to have greater benefit. What about using apheresis to physically remove the Lp(a) from the circulation? Most of the data that we have looking at this question comes from Germany, where Lp(a) apheresis to lower Lp(a) is reimbursed by their state system. And so, again, looking at this data from Rösler et al., you can see that before apheresis, the MACE event rate was pretty high, and that during apheresis, the MACE event rate looks like it's much lower. This is observational data, and the thing that you have to realize is that actually many patients start apheresis because they have a MACE event. So a lot of patients may have been commenced on the apheresis because they'd had an event just prior to this. So you have to take this data with a big pinch of salt. Similar data from Italy showing again this observation that you have lower MACE event rates during the apheresis period compared to before. I think the best data that we have is from Tina Khan et al. And this is data from the Royal Brompton, where they went to the effort of doing a sham versus an apheresis arm as part of this study. So it was a crossover study, and they looked at patients who had high Lp(a) and refractory angina. And the patients each had a 3-month period of either apheresis and then sham, or sham and then apheresis. And the patients obviously didn't know which one they were having at each time. But you can see from the myocardial perfusion data here that with apheresis, there was an increase in perfusion. So that's, again, suggestive that lipoprotein apheresis would be helpful in this population. However, it's important to remember that when we do apheresis, we don't just remove Lp(a), we remove lots of other things like clotting factors, etc. And so it may, we can't say for, with definitive certainty that it's the removal of Lp(a) that is causing this benefit. So there's a lot of excitement and a lot of work being done in this field currently, and there's several Lp(a) targeted therapies that are in development, and we're certainly involved in several of these in the phase 3 studies that are currently ongoing. And these include an antisense to apo(a), as well as siRNA-based therapies to apo(a). And these can really robustly reduce Lp(a) by about 80 to 90%. And this is just data from one of this. This is Pila-Carsan, which is the siRNA-based therapy. And you can see 80% reduction in Lp(a). And these studies should be reporting in the next year or two. So we will have that definitive answer as to whether lowering Lp(a) can reduce cardiovascular risk. So in terms of treatment, what the Heart UK's statement currently says is that management of patients with raised Lp(a) should include, firstly, lowering their overall atherosclerotic risk, so using things like statins and controlling all their risk factors, controlling their dyslipidemia. And in those patients who have, very progressive disease and very high Lp(a), we should consider lipoprotein apheresis. And we should really manage all their risk factors. So this is about, there's a holistic approach, and it's not just about the LDLs, but all their other risk factors as well. And then in terms of targets, we talk about in patients with raised Lp(a), we should really be aiming for an LDL target of less than 1.8 millimoles per liter. And that's sort of in agreement with the JBS3 data. In terms of further research, we haven't had time to touch on this, but development of commercial, truly isoform insensitive assays is really, really important, because if we have new treatments out there available to us, we need to be able to make sure that we are measuring Lp(a) as accurately as we can. And then randomized controlled interventional studies that selectively lower Lp(a), both in primary and secondary prevention, would be of use. I mean, the studies that I've shown you that are in development are predominantly in secondary prevention. And then finally, it would be wonderful to have an RCT that specifically answers the question of aspirin. So looking at aspirin in primary prevention and seeing whether we can mitigate some of that prothrombotic risk. That's it. Thank you for listening. And here is the QR code for the feedback that I think you can access just using your phone. Oh, you're on mute, Amir.
Thank you so much. Really superb talk, Jaimini. So we've got a couple of questions. So in order to get your certificate, as Dr. Sutler said, please scan the QR code. There's a very quick feedback question as per previous masterclasses, and then you'll get your certificate, which has got both Royal College of Physicians and Department of Health accreditation sent to you. Just make sure you spell your name correctly, because that will appear on the certificate. So a couple of questions, Jaimini, in the chat. At what age would you recommend a lipoprotein A to be measured?
That is a great question. So currently in the UK, our recommendation is probably to wait to adulthood, because there's not great evidence of, unless you've managing the Lp(a), we don't have any data in pediatric populations of starting statins, etc. At an earlier age, and I think it can cause a lot of anxiety amongst families when you measure something, but you can't necessarily or don't know what to do about it. Certainly with genetic dyslipidemia, so patients with familial hypercholesterolemia, and particularly homozygous familial hypercholesterolemia, we would measure Lp(a) earlier, but not in the general population as such.
Thank you, Jaimini. Some biochemists advise that the assay is very variable and limits the clinical utility. Do you think this is being addressed to enable wider use?
Yeah, it's a really important point. And there was, we've known about Lp(a) since the 1960s, and a lot of the data that initially came out from the epidemiology was due to poor assay methodology. And that has been addressed partly by the IFCC and WHO. There's been a lot of work done to standardize the assays, and we've got a reference lab in Seattle where commercial providers can get their assays certified. And that's what we should be doing as clinicians, is making sure that labs are using assays that are certified and calibrated to national standards. There are certainly several commercial providers that are able to provide this. And I think when I've looked at the data, certainly in the UK, more and more labs are using these certified assays, but there is certainly still work to be done.
Thank you. And do we know if inclisiran impacts lipoprotein A level, and by how much?
Yeah, I think it's about 10 to 15%. It's quite modest, and so yeah, and it's certainly not licensed for specific Lp(a) lowering. It's more the the LDL lowering that we're using inclisiran for.
When can you use both aspirin and statin together for raised lipoprotein FH?
We do this commonly. So particularly if I've got a patient who's got, so in primary prevention, presumably we're talking about primary prevention because secondary prevention, they're going to be on both of those anyway. But in primary prevention, if you've got someone who has particularly a strong family history, they've got very raised Lp(a) and they've got subclinical atherosclerosis, then I would be very tempted to use both of those. And you have to discuss the risk versus benefit of the aspirin, and look at the bleeding risk as well in that specific patient before starting. But certainly, there are patients in whom I think they certainly would benefit for both of those drugs.